Hello, and welcome to this next session of the Globe Summit. I'm Elaine Chen. I'm a reporter at STAT covering heart disease, diabetes, and obesity, and I'll be moderating today's panel on the next generation of obesity drugs. You've probably heard of Ozempic, Wegovy, or Mounjaro. These are all medications that can deliver substantial amounts of weight loss and have ushered in what many see as a revolution in obesity treatment. We're going to discuss the significance and impact of these drugs on the medical field, but also on society and how we think about weight and health. Joining me on this panel are, farthest away from me is Caroline Apovian. She's the co-director of the Center for Weight Management and Wellness at Brigham and Women's Hospital. And then Josimar Mate, an associate professor of nutrition at the Harvard T.H. Chan School of Public Health. And lastly, Nick Marston, a preventive cardiologist at Brigham and Women's Hospital. And as a reminder, we're taking audience questions, so feel free to submit questions at any time during this session, and we'll try our best to get to them. To kick things off, the drugs that we have now, these new drugs that can lead to substantial amounts of weight loss, they started out as diabetes drugs, like Ozempic, for example, which is a diabetes drug. But as researchers ran studies in diabetes patients, they noticed that people lost a lot of weight on these drugs, and so now we have, now companies have tested these drugs in people with obesity. So now we have obesity drugs like Wegovy, for example. Caroline, can you explain how these drugs work and how they lead to substantial weight loss? And can you also contextualize for us how significant is the amount of weight loss that we're starting to see with these new drugs?
It's a great question. GLP-1 is really the gut hormone that these are replicating that hormone in the gut. And what GLP-1 does is it increases insulin secretion by the pancreas with high glucose levels. So it doesn't, if your glucose levels are normal, it will not produce hypoglycemia, which is a very important point. And it also works in the brain, in the energy regulation system in the brain to produce satiety. Also leads to decrease in gastric motility and gastric motility. So these drugs were first developed for diabetes because of the increase in insulin secretion, but very soon, we realized that they caused weight loss. And the weight loss is far and away much more robust than the older medications that are still on the market. And so now we have semaglutide, which is both Ozempic and Wegovy. It's the same drug. It produces an average of 15% weight loss, which is 50% more weight loss than older agents. And so that is why there's been such a remarkable boon in trying to gain access to these medications, and the obesity medicine subspecialty has also gotten a big boon with providers wanting to be trained in this emerging field.
Yeah. And with some of the newer versions that are in development, we have Mounjaro, we have some other ones that are in development or, on their way to potentially being approved for obesity. Some of them are reaching 20% or even higher weight loss. And so it's the first time that we have medications that are approaching levels of weight loss that we see with bariatric surgery.
That's right. So Mounjaro gives an average 22% weight loss.
Yeah.
The sleeve gastrectomy starts at 25% weight loss, and the Roux-en-Y gastric bypass, you'll get 35% weight loss. And these drugs really are modeled after what happens in bariatric surgery, and we know now that bariatric surgery is not a malabsorptive or restrictive procedure. The reason why it works so well is because it changes the gut hormone milieu of these drugs, of these agonists, and others. And that's why it works so well, because it's modulating the secretion of many different hormones, which leads to the body's a lowered body weight set point, the defense of a lower body weight set point in this environment.
Yeah. So more broadly, Caroline, can you talk about, what do you think about how these drugs are affecting how society could view obesity?
Yes, these drugs have really illuminated what we've known since really 1994, 95 with the discovery of leptin by Rudy Leibel and colleagues. And he published a paper showing that your body weight is regulated, which means that he put patients in a metabolic chamber and had them gain weight and lose weight, and the body did things to your energy expenditure to get back to your regular body weight. And so that we knew that in 1994-95. Translate to today, now we know that there are medications and surgery that can help regulate body weight in a permanent fashion, as long as you take the medication, to help regulate your body weight downward. And people who take these drugs say they feel full for the first time in their lives. And they say their whole outlook and lifestyle changes. If you talk to patients who are able to talk to you about what has changed, they tell you this. And it's all because of the hormone. And the hormone is regulating so many aspects. It's increasing your energy expenditure. Mm-hmm. And it's making you want to go to the gym and making you want to eat healthy food. It's really amazing when you talk to patients. And so patients realize that they've been dealing with a disease, that it's not a matter of willpower, it's not their moral failing, it is not, they shouldn't be stigmatized, and they're standing up and realizing they shouldn't be stigmatized for this disease.
Right. Right, exactly. So this drug, which is acting on biological mechanisms, in being so effective, mm-hmm. you think is showing people that the underlying condition that they have is due to biological causes.
That's right. And remarkably, I'm finding suddenly, now it took about 6 months to get the media attention on these new drugs, that people are coming in and more amenable to the idea of bariatric surgery, mm-hmm. because they suddenly realize it's a disease and it's not a easy way out. I used to get, that's the easy way out, doc. I don't want that. I know I can do it on my own. And now, instead of saying I know so-and-so who died, they're saying I know so-and-so who gained all the weight back. But what needs to be understood is that obesity is a chronic, relapsing, progressive disease. So yes, after you have the Roux-en-Y gastric bypass or the sleeve gastrectomy, you may start to regain some weight after 5 years, but that's because the environment hasn't changed. And whatever it is that caused our bodies to defend a higher body weight, we think it's inflammation in the brain, is starting to mm-hmm. get inflamed again.
Josemar, I want to bring you in. What are your thoughts about the significance of these drugs in the context of the work that you do? And do you have any concerns about the focus of these drugs potentially putting too much weight or kind of focus on weight loss?
No pun intended. So yes, and I do agree. So my work is mostly on nutrition and health, and including obesity and other cardiometabolic diseases in minority populations and how that comes across in public health. And I totally agree that these medications have completely changed how we talk about obesity in society. And that is because they have been recognized as a medication, as a condition, as a disease. But in that sense, that has also changed how people see it, how the medications are seen as sometimes a way out of also, now I can just go and take this medication, rather than just going through all of the behaviors. And how these are prescribed is still something that we need to discuss. Sometimes I have seen this being prescribed in spas, in medical clinic, in non-medical situations. And the other situation, this is being prescribed just specifically for weight loss, when they were originally prescribed for diabetes. Yes, we do see the weight loss, but there are other conditions and other situations that we should consider. When the focus is shifted to weight, then we are still considering obesity as not a disease, but rather as a body image situation, because we're focusing on the weight loss. Mm-hmm. So we're still talking about body image and condition. And I think that what some of the companies have been marketing these medications as is, just let's lose weight, just let's take control of your body. And it's again talking about, focusing on the weight rather than on health overall. And this is again re-stigmatizing obesity rather than considering overall health.
Something that is I think relevant when we're talking about like, do these drugs only lead to weight loss or are they having other health benefits, is we had an important result that was reported last month from Novo Nordisk, which is the company that makes the obesity drug Wegovy. And they announced that in a large trial, Wegovy cut the risk of major heart complications by 20%. It's a pretty significant amount. And this is the first time we actually have an obesity drug that shows cardiovascular benefit. We only have this 20% number. We don't yet have full details of the trial. But Nick, I do want to get your thoughts as a cardiologist. How significant is this 20% risk reduction, and how does this affect the way that you're thinking about and approaching patients?
Yeah, it's a great question, and it was a very exciting trial. Anytime our outcomes trials reach, 20% relative risk reduction or greater, we get very excited in cardiology, and then we kind of start to get involved in these fields that may have not yet involved the heart. And so I think that's what we're going to now see with obesity. I'll just take maybe a step back and say that GLP-1 receptor agonists have been used obviously in diabetes. They've been approved for diabetes. We have done cardiovascular outcomes trials in the diabetes space, and those have been significant and have showed significant reduction in major adverse cardiovascular events like heart attack, cardiovascular death, stroke. So we have been using this class of drugs in the preventive cardiology clinic. However, we've only been using them in patients with diabetes. And so I think, our mindset in the preventive cardiology clinic is thinking about kind of the axes of someone's cardiovascular risk, right? And we have some very tried and true pathways like lipids. We've got great drugs and a lot more coming. We've got hypertension. We want to treat that. Diabetes is actually relatively new because it used to be our diabetes therapies did not reduce cardiovascular risk. And then with those outcomes trials, the GLP-1s and the SGLT2s, we're seeing reduction in risk. So that was big, and that really got cardiologists' attention and focusing on treating diabetes as an axis of risk. We have inflammation and others, but now with the SELECT trial, what's unique about this trial is it's 17,000 patients who do not have diabetes, but they have established atherosclerosis, meaning heart disease or stroke, and they have obesity, overweight or obesity, so the BMI had to be above 27. And then to still see that this drug significantly reduces major cardiovascular events outside of diabetes is great, because we can take what we've been doing for a segment of our population and expand it to an even broader population, those with heart disease and obesity. So, that's very exciting. It kind of parallels what we saw with the SGLT2 inhibitors, dapagliflozin, empagliflozin, and others in that class, where the drug was initially approved for diabetes. The outcomes trials showed benefit. Now we're using it in non-diabetic patients. We're using it for heart failure. We're using it for kidney disease, even if they don't have diabetes. So I think we're seeing a very kind of parallel path, which is, really exciting for obesity. It's really a new kind of paradigm for managing risk.
Right. And so, this is a new kind of interesting data point in this discussion of like, what benefit do these new obesity drugs offer? Is it just weight loss? This trial suggests, no, it's not just weight loss. We also have cardiovascular benefit. But a question that I have is, going back to the importance of how the question of how important is weight loss, what do we know about how much of the heart benefit is actually caused by the weight loss? Because we don't have a causality yet. So what do we know about what's causing the cardiovascular benefit?
Right. No, we always want to know why. And again, to go to kind of in the lipid space, it's so clear cut, right? We know if you lower LDL by 40 milligrams per deciliter, that's going to translate to about a 20% relative risk reduction. So before the trials you've done, you really know what to expect. Here, it's not as clear. It's not a single pathway. It's more complicated. The multiple cardiometabolic pathways are involved, as you pointed out. And so I think ultimately it's multifactorial. I think that the weight loss is a key component. Downstream of weight loss, you can then have reduction in cholesterol levels. You can have reduction in blood pressure. It'll be interesting to see what those data look like in this trial. And in others, the A1C reduction is more significant than other therapies. So perhaps that's part of it, although historically A1C lowering hasn't always tracked with cardiovascular benefits. So that's not as clear cut as something like LDL reduction. And then could there be other pathways? And one that's kind of been suggested is an anti-inflammatory effect with these therapies. The GLP-1s can reduce high-sense CRP or CRP in general. That's a reactive protein and a marker of inflammation. IL-6, another marker of inflammation. These are can be lowered with these drugs, and I know those are measured in the SELECT trial. So when the SELECT trial fully is published, peer-reviewed, presented, we'll see a lot more data, and I think that'll be coming at one of our upcoming cardiology conferences.
So I guess right now it's not yet clear what the exact mechanisms are that is leading to the heart benefit. And I asked this question because it has implications obviously for medicine, but also for this broader discussion that we were talking about in terms of, how much emphasis should we put on weight loss when we're treating people. Josemer, I want to bring you back in. How are you thinking about these heart results and, how it affect or may not affect the way you think about, how much focus we should be putting on weight loss?
I think that's exactly the point, that if we can show those results and these medications work, we can use the medication, and the medications have good benefits, and they have been proven, and that's awesome. We can just change the language around the medication, and instead of focusing on the weight loss, focus on the overall health benefits. And I think that has been the overall problem with obesity, is the language that we use around it, is the problem with obesity, the epidemic of obesity. Obesity is bad. That is always the problem. Lose weight, change your body. Rather than that, the medications are there. They have additional benefits and other benefits in addition to the weight loss, if we can figure out what those are. And these trials are coming up now, showing those benefits. Change that language and refocus what those are. Benefits for cardiovascular prevention, benefits in lipid reduction, in addition to the weight loss. That can change the language, and then that could help with the use of the medication.
Yeah, I feel like there are some different ways or different maybe concerns when we're talking about treating patients now that we have these new drugs. On one hand, Caroline, you've brought up how we want to take obesity seriously and we want to treat it as a disease. But on the other hand, Josemer, as you mentioned, there's a concern of kind of focusing too much on weight loss and that potentially further stigmatizing people with bigger bodies. Like, Caroline, how are you thinking about these concerns and maybe striking a balance in terms of how you talk with patients and how you just think about these drugs in general?
Well, the AMA is really helping us with this. They put out a policy recently that we need to find a better measure of body fat than the BMI. And that's going to be about 10 years away because the BMI is just too convenient and too inexpensive. You just need the height and the weight. There are other ways. We have equations for body mass risk, and we have another equation called the BAI. But they also don't really get to the problem, which is where the fat is in the body. So eventually, I think we will have either a marker of deleterious adipose tissue, or we will be able to do a 3D scan in patients, say coming in, you just scan them and you know where the fat is and how bad the fat is, or how inflamed the fat is. But I think that's going to get us closer to really getting to the heart of obesity, the disease, rather than, you need to lose 20 pounds because you don't like the way you look, but all that fat is in your thighs and it's healthy fat. It's not inflamed. And you still may want to lose weight for your personal appearance, but that is not obesity, the disease. So we're not there yet.
Another issue I want to bring up with these drugs is insurance coverage. It's not easy getting coverage for these drugs for people with obesity. Caroline, can you tell me about the experiences that you run into? What are some of the challenges that you experience? How many more people have you had to hire just to deal with insurance challenges?
Yeah, we saw 10,000 patients for obesity last year. We have a 4,500 patient waiting list. And everyone, of course, as you can imagine, is coming in needing and looking for medication to help them, and we try our very best. But we know right off the bat that Mass Health, Medicare, and Medicaid do not cover our anti-obesity agents ever. And it may be changing now in Massachusetts. Hopefully that is the case. But as of right now, they don't cover.
And is that kind of a remnant of viewing obesity drugs not as a medical treatment, but as a cosmetic kind of intervention?
In Maine, for example, Blue Cross Blue Shield and other insurers call these vanity drugs.
Yeah.
That exactly points out what you're trying to say. They're vanity drugs. And this is despite the SELECT trial and all of the evidence that we have that lowering your BMI will improve risk. So it's really a remnant of the older theories, and really a remnant to fen-phen in 1995 and in the dark ages of obesity treatment, thyroid hormone and all those hormones all those medications that were deleterious to health, phentermine and things like that. So we really have to change that mindset. And it's very difficult to do so because someone's going to have to pay up front.
Right.
And they're going to see the benefits not in a year, not in 2 years, not even in 5 years maybe. So they're going to the benefits are going to come in later on when you don't develop heart disease, diabetes, hospitalizations, and other medications for all these diseases that are caused by obesity. So the government really needs to step in, the community, doctors, to try to subsidize and support the use of these newer medications in 42% of Americans who have obesity.
Right. And I recall, I think you've told me before, you had to hire some more people in the office just to deal with all the insurance challenges with these drugs specifically?
Every single prescription for one of these agents has to go through what's called a prior authorization process, which can take days and weeks to try to get the farm tech that we have one farm tech, we're trying to hire more, has to go through a process where she contacts the insurance company, gives them information, and then the insurance company will come back and say patient doesn't qualify, or if the insurance company blanketly does not cover anti-obesity medications, they will say that we have no idea. Aside from Mass Health, we don't know if the insurance company will or will not cover. It has to go through that PA process because all of the insurance companies are different. They have different plans. For the most part, we know that Blue Cross Blue Shield is, sometimes covering, in general, of the private insurers, about 20 to 30% of the private insurers will cover. That means 70% don't.
Yeah.
So it's a process. By the time we hear, it could be a week, it could be 2 weeks, and then the patient is left with nothing. So we have to figure out what they can take instead, and it usually ends up being phentermine, topiramate, all of the other agents that have been on the market and are good, but they don't reduce blood pressure and pulse, and they have other side effects because they're not naturally occurring hormones.
Yeah. Josemar, how do you think these insurance challenges affect, existing health inequities?
Well, that's a very good point. And the fact there are two things. First, the fact that there has been a really high demand of these drugs has created a shortage. And there's one thing with that is that the people who really, really need it are being affected. And that tends to be people who have higher rates of diabetes, which is the main reason where these drugs were created for to begin with. And those tend to be people of racial and ethnic minoritized groups or people with low income predominantly. And these people have been affected. They cannot find the medications. Most of these have been deviated, as I mentioned, to health spas. I walked into the medical spa clinic the other day to get a massage, and there's a sign right there, get your Ozempic today. And I almost died. What's this? What's happening? And those are the things that are happening. These medications are being sold and are being done in other ways.
Those med spas are getting their drugs from China and India. So it's illegal, and we don't know what's in the stuff.
Right,
and that creates even but that creates an even bigger issue, precisely that we have an unregulated medication of all of this. And the second issue is that most of the people who have higher rates of diabetes are also groups of racial and ethnic minoritized groups and low-income populations. And these are the people who might be needing the medication for actual obesity as a disease, and they cannot get access to the medication because of low insurance rates. No, the other thing that I need to mention absolutely is that obesity, as you very well said, Nick, is that it's very multifactorial. There are many reasons for this. And for groups that are minoritized, it's not necessarily because they have not access to low insurance, but they might not have access to the right choices of food, and there are other environmental factors that might be happening that might even contribute to even higher obesity rates. So these compounding factors that are just contributing to more obesity on top of not having the access to the medications. So this is just pretty much like all against them.
We also know that in ethnic groups, that based on their BMI, they could be at higher risk for NASH, NAFL, the fatty liver disease, type 2 diabetes, and heart disease. So at lower BMIs, they get these diseases more often. I have, and then there are patients who have more time and resources to go around and look for these medications that are out of stock and find them, and where they find them is in the low income areas.
Yes, I've seen a lot of people online talk about how they spend so much time just, calling all the pharmacies.
But they're finding them in low income areas because those patients who live there don't have access.
All the insurance.
Right, exactly, So, you brought up a good point, Josemar, about for obesity, especially, for a lot of people who live in lower income communities, it's not just, there's a lot of environmental factors that go into it. Where do you think, like on the topic of insurers, like is there anything that can be done to increase access there?
Yes, and this is something that we have had some discussions with. It's that all of these medications are being prescribed with some restrictions, of course, and with some eligibilities. But there is an opportunity, and I think that some of the companies and some of the insurances are missing an opportunity here to go prescribe these medications along with educational counseling and nutritional counseling, and prescribe also nutritional foods. And there is this concept of food as medicine that is precisely prescribing food as medicine. And we have plenty of evidence and plenty of clinical trials and plenty of studies of years of people eating healthy foods year after year after year after year and not developing cardiovascular disease or diabetes, especially with evidence on fruit and vegetables. And we can provide that and we can prescribe that through insurances as food as medicine. And that could be a really good opportunity for health insurances to do that as well.
And I'll just add that I think the cardiovascular benefits definitely can help get insurance coverage eventually, but the way it kind of works is the trial is done, then it works its way into the next iteration of the guidelines where, expert consensus or scientific statements or national guidelines are recommending this drug as a therapy for a certain group of patients. And then sometimes that's when insurance companies are much more pressured to cover these drugs. And so with the SELECT trial, hopefully this will help the cause. However, I would just caution that it's, again, in patients who have established atherosclerotic cardiovascular disease, right? So have already had an event, MI or stroke, or some form of atherosclerosis. And so while that's great for that group of patients, I imagine a lot of the patients you're seeing in clinic are younger in life, and really the benefits are greatest early in life where you have decades of time to kind of change that trajectory, right?
Yeah, we're
lower the weight.
That's exactly right. And we see FDA approval now for these agents in younger and younger people, in adolescents and children, and that insurance coverage is not going to get there so quickly.
This brings me a great transition to one of our audience questions. Like you said, Wegovy is now approved in adolescents. So potentially we could have really people who are quite young taking these drugs for quite a long time. So one of the audience members is asking, what do we know about the safety of taking these drugs long term? And what do we know about, do you also have to stay on these drugs long term to get those downstream benefits, for example, for cardiovascular benefits, maintaining low blood sugar? Nick, why don't we
I could start, yeah. I mean, I think one of the benefits of an outcomes trial, we think of it as like looking for the benefit in terms of outcomes and reducing cardiovascular events, but equally important is the safety outcomes, right? Phase 2 trials are typically shorter, smaller populations. So when you do a large outcomes trial, 5-year follow-up in 20,000 people, you also gather a lot of important safety data. So, the top line results for SELECT that were announced reported, good safety and tolerability, but obviously we're going to want to dig into the details when they present that and publish it. Because prior studies are much shorter. That said, these drugs have been around, and we've been using them for, at least lower doses in the case of semaglutide for over a decade. And so, there's side effects with nausea and vomiting and things like that in the short term. But maybe I'll turn it over to you for any concern of longer term effects. But I do think you'd have to stay on these drugs like you do cardiovascular medicine to see, cardiovascular benefits. Lipid-lowering therapy, antihypertensives, diabetes medications, these are typically chronic, lifelong therapies, and coming off of them usually kind of erases that benefit.
Yeah, again, we've learned everything that we know about gut hormone analogs by looking at bariatric surgery. And so bariatric surgery outcomes are also a 20% drop in mortality with bariatric surgery. We do adolescent bariatric surgery, and the younger the patient, the better they do long term. So if you can avoid even getting prediabetes, diabetes, insulin resistance, lipid plaque, and fatty liver disease, you're going to do better in the long run, and that is coming out in the bariatric surgery long-term studies, labs, adolescent labs. That's the big databases looking at adolescents. In terms of the how long do you need to be on these drugs, we do know that as long as they've been studied, if you stop the agent, you will gain the weight back. And no one knows really if you will gain the weight back if you're on the drug for 5 years or 10 years. You really don't know that. And the originators of the research that led to us to realize that obesity is a disease, and this is colleagues at University of Washington who did animal models and made them have obesity with a high-fat diet, and then sacrificed them and looked at the energy regulation system in the brain. There was inflammation there that did not allow the satiety signals to get in, and the animals defended a higher body weight. And this seemed to be permanent. And then they also looked at the brains of MRIs that were done in obesity in humans and found the same inflammation. We don't know if that inflammation will ever decrease. That's the stuff we don't know.
We have 1 minute left, so Josemar, I'm going to come back to you on this question. Obviously these drugs cost a lot of money, as we've mentioned. That's why insurance companies are so reluctant to cover them. It would be really costly to have people stay on them for the rest of their lives. How important do you think, or how critical do you think it is to figure out an answer to this question of how long people should take these drugs for? Is there a way to wean them off?
There is no discussion around how long you need to take statins or any other drug for any other disease. Why do we have to deal with cost effectiveness for obesity? The reason why we're dealing with cost effectiveness for obesity is because obesity is really not considered a disease. We never talk about, the cost effectiveness of stent placement, which quite frankly The COURAGE trial showed that stents plus medications versus medications alone, there's no difference in mortality for angina.
Yeah.
Yet we do stents all the time, and they're very costly.
Yeah. Quickly, Josemar, do you have any last thoughts you want to add?
The medications work, but we also have to provide nutritional counseling and establish healthy eating habits.
Okay, great. Well, thank you so much. That's all the time we have. It's been
Good enough for you.
it's been a pleasure moderating the session,
get to talk
and
about that.
I'm so glad that
Certainly.
you all joined us
Very
for the
important.
session. Thank you so much.